StreamYard is awesome. I am so excited about this topic, Erin. We actually never get to start where I always actually want to start every single podcast, every single webinar, every single interview that someone asks me to do. And we never actually start with the actual person we're talking about, right? Like if you, and I want you to go with this with me because you've been in this position, but if you're a mom, right, who's
Mhm.
about to deliver in a hospital, what would you want to know?
Oh, man. I feel like the information gap is just so tremendous, for most of us, whether we're healthcare providers or not, going into pregnancy and childbirth. There's so little that we know, um, from just the basic anatomy of our private parts to the different stages of labor to the different options for how you can deliver. There's so much we don't know. But I think the thing that I feel like I bring up over and over again when I do my community class for parents in my area is emphasizing that you're in control of your own body, right? You're in charge of your body. You're in charge of the decision making that happens here. And don't be afraid to ask questions and advocate for yourself. I think is probably the most important thing because the idea that someone's going to be able to go into birth as an expert just knowing everything is probably not realistic. But what you can know is that you are not a passive participant that is at the mercy of the healthcare system and the healthcare providers that are there. Because I hear stories all the time from moms who say, "Oh, I didn't realize I could say something when something didn't feel right. They thought they just had to go along with the system."
Okay, so do you ever, because of what you know, and because of almost like an accusation that if you provide all this information on the back end, you're overwhelming the mom. So are you constantly in this push and pull of how much information do I provide on the front end? And then how much information can I really provide them really early on in the
Mhm.
hospital stay on the back end?
Definitely, right? And I think the very first time I saw my first patient in postpartum in the hospital, I definitely think I did information overload. I was probably in there for almost an hour, which is an eternity. If you work in a hospital, you know that is an eternity to be with one patient. Usually it's 20 to 30 minutes per patient. I was talking too much. I wasn't picking up on their cues that they were glazing over. um, but so there's definitely a time crunch when you're in the hospital after someone's given birth. They're going to be leaving probably that day or the next day. You're only going to see them for 20, 30 minutes. So what do you really want to prioritize? And that's really hard. And it comes with experience and practice, I think, figuring out what should I prioritize, just like it would for any patient population, figuring out what do I need to say, what do I need to just kind of not say right now. But I do think the idea that adding a physical or occupational therapist to somebody's plan of care in the hospital after birth is just going to be too much for their little brains to handle is feels insulting, right? It feels
It is
like you're
so
saying,
insulting. Like, "Oh,
yeah,
we can't see anyone after a stroke because they just had a stroke." I mean, I'm just like, "Hear you,
yes,
do you hear yourself? Like, do you
I know.
hear
And
yourself?"
yes, and people who have strokes often have real cognitive impairments where their
Yeah,
brain actually is truly is not able to retain information, right? Or understand the words you're saying to them. And we would never advocate for therapy not seeing them because cognitively they can't handle the information. But that's not the case for a postpartum patient who is completely in control of their normal faculties, right? They have not had probably an event that has affected their ability to understand information. They've been through a major medical event. They're probably going to be physically tired because giving birth is exhausting. They may be in pain. They're caring for a new baby, which is a whole new ADL that they've added on. And they're probably not sleeping very much because babies have to be fed every 2 hours. So there's definitely things that are going on that could affect their ability to be 100% focused on what you're telling them as a therapist. But that's true for every provider that comes in,
mhm,
right? So part of your job as a healthcare provider is to understand where your patient is at, to have that individualized conversation with them and gauge, right, where you think they are and what information you think you should prioritize. The answer isn't just to throw up your hands and say, you know, well, this little lady isn't going to be able to understand anything. So I'm just not going to bother providing her education that could be really valuable,
exactly, I'll
right?
give you one. This was so unusual. Like, usually we didn't have patients ask for physical therapists during their high risk pregnancy stay. But I had a mom from Salida, Colorado, right?
Yeah.
And who was
Life.
familiar with the program that Ann Krogan started. And she asked for physical therapy. She was in the hospital 2 hours away from home, right? And
Mhm.
asked for physical therapy during her high risk pregnancy stay. And I'm telling you, like in her room, she had stacks of research papers that she had
Wow.
had her husband, bring to her. She was researching constantly on her computer. Every time the OBGYN like walked in, she was ready to like let them know her goal was to stay as
Mhm.
pregnant as long as possible before she delivered, right? And
Mhm.
they were constantly telling her, listen, your baby's got to go to the NICU. If they're born, earlier than 35 weeks, I'm sorry, you're going to have to separate. And she was not having it. And so, high risk mom,
Mhm.
preeclampsia, we started a program where she could walk around the unit, eventually walk to where she could walk outside and enjoy some fresh air. But like that was her initiating
Mhm.
therapy. That was her looking up research, advocating for herself. And I'm like, how insulting is it to tell someone that they don't have the faculties to have rehab or make decisions that pertain to their care? It's insulting to us and it's insulting to them,
It is.
right?
I mean, that's really amazing that that mom was able to advocate for herself, but I think a lot of the healthcare system, I mean, it's rooted in a very paternalistic model of care, right? Not just for maternity care, but all healthcare, right? There's very much this hierarchy, right? Where providers, especially if they have a white coat, are kind of at the top of the pyramid. And it's
Right.
sort of expected that you will do what they say, right? That you will be a compliant patient, right? Often in medical charts, non-compliance is written as a negative about a patient, right? Not compliant with their care. And oftentimes, conversations aren't had with patients, I think, at the level they need to be had at to truly be giving informed consent for their care. And I think that may be particularly true in maternal health care, right? There are studies showing that a large percentage of moms feel like their experience interacting with the healthcare system when they were pregnant was not super positive, right? Or that they did have trauma associated with giving birth, some of which probably could have been avoidable if they'd had a more collaborative, holistic healthcare team. And I think PTs and OTs particularly really understand the importance of that patient autonomy, because what we're taught in school is that, look, we don't want to get patients dependent on therapy for the rest of their lives, right? We want to be able to teach them to manage their own care, right? If you go to outpatient physical therapy, they're not going to tell you you need to come every week for the rest of your life or every month the rest of your life. The goal is to get you independent with managing your own symptoms, including if whatever you're coming in for comes back. So I think as providers, we are trained with that mindset that the goal is for the patient to be able to manage themselves independently in their environment that they live in. So when we apply that to maternal care, right, I think we really bring in this, well, the patient's really the driver, right? Their life is really going to dictate what we should be doing with them so they can be as independent as possible and feel as empowered as possible.
So I was actually taught that too.
Mm.
I think I went to a pretty good PT school, right? Where I was taught, yeah, you don't want someone to be dependent on physical therapy the rest of their life. And then I entered into the world of pelvic health and women's health. And I said, what in the flip is this? Why am I treating women like routinely with lymphedema, these lifelong impairments, like huge arms, huge legs, who are dependent on me? And I'm talking years of plans of care, years of even pelvic floor dysfunction, incontinence and pelvic pain, that they went through one round of physical therapy and then another round of pelvic health here and another round of medications or surgery here. And I was like, so if we actually want people to be independent and not dependent on us, why would we not see someone within a few days during their hospital admission after a major abdominal surgery like a C-section? Why would we not see someone as physical therapists
Mhm.
after a hysterectomy, after a mastectomy, after lymph node removal for cancer surgery? Why would we actually wait until they develop lymphedema and pelvic floor dysfunction and then have to see them for years. And then some will say, "Oh, well, if you're really good, you don't have to see them that long." Listen, okay? Just stop, okay? Like, that you're not making any sense. Someone had a knee replacement, and you let them rest over a pillow for 6 weeks, and then you saw them after 6 weeks, and now they have, like, flexion, contractures and stuff like that. You would be changing something really, really fast. So, the same applies in women's health and maternal health care. And so the question I have for you, Erin, is what do occupational and physical therapists need to know to treat this population in the hospital during their high risk pregnancy, immediately after birth? Because I'm going to tell you right now, in 5 years' time, we're going to have to know what to do. Okay. Therapists
Mhm.
will have to be prepared to treat this population because people are going to see the disparities in rehabilitation, the disparities in healthcare, where one person is
Mhm.
offered an OT or PT after their surgery and another person after their birth is not.
Yeah.
It's not sustainable. What do they need to know?
So I think that as a PT or OT that wants to work with this population, it can feel a little intimidating if you didn't learn anything about it in school, which I think is true for most currently practicing PTs and OTs. I know we both are hoping that in the future that will start to change, right? That PT programs will start to integrate and OT programs more maternal, right, healthcare and rehab into the program so that we're coming out of school with already at least an entry level amount of knowledge so that we could start working in a hospital and go see somebody. But right now, today, that's just not true. That so most therapists, I think, feel like they have a real blind spot for this population, and that's scary because you don't know what you don't know. You don't want to hurt somebody. You don't want to miss a serious tell someone they're fine, but you missed a serious complication because you didn't know, right? Some detail that's specific to this population. So I would say if you're a PT or OT that wants to work with this population, um, you could benefit from doing some amount of continuing education, especially if you feel like you just don't know anything about pregnancy, right? If you don't know what a cervix is, for example, right, you could probably benefit from some amount of continuing education just to learn the basics. There are a lot of great CU classes out there where you'll learn the basics of pregnancy. I know the Pelvic Health Network offers some, right? I have an introductory course that people can take that's 5 hours where we'll make sure you know the basics of pregnancy and postpartum and what you need to know as an acute therapist to make sure you're not missing something. But I would also say don't sell yourself short on the skills you already have, right? You know how to monitor somebody's vitals with activity, right? You know how to monitor someone by physically observing them and talking to them to recognize signs that they're decompensating or that something's not right, right? You know what the symptoms of high blood pressure are, or someone having a cardiac event, or somebody having a stroke, or somebody developing a blood clot. So, those are all signs that you could recognize in a postpartum patient right now today without any other training, right? You know how to go see somebody after they've had an abdominal surgery and what kind of education and training is really important to make sure that they understand so that they can meet their home demands without harming their new incision. You can go do that right now today for a C-section patient without having to do additional training. So I would say that there's real benefit that you can provide to somebody right now if you just keep your normal clinician hat on and don't freak out that it's a population that maybe you haven't seen before.
I think when I first started in acute care, I had never like really treated someone in the ICU. Like there
Mhm,
was such a large like learning curve for me. But I think what people,
mhm,
miss the boat on really is even if you didn't have that exposure in PT school, there's someone in the hospital who can train you, who can onboard you, who can give you the mentorship and all of that. And
mhm,
I honestly I do agree with you. Like, yeah, probably you'll need continuing education, but what's really lacking in hospitals are just those therapists who can mentor someone on the maternity unit, right? And so if you don't have mentorship and you don't have, that access to just background on what this population looks like, you as an acute care therapist have been trained in a way that many therapists in other settings have not been. You've been trained
mhm,
to see anyone coming through the door. And so I didn't necessarily have PT at school education on the homeless population who also had, a toe that was, gangrene and they were facing amputation and all of this stuff. And I felt like I was thrown into the environment like, "Oh my gosh, what am I supposed to do?" But I had a team to bounce ideas off of, right?
Mhm,
And that to me was a game changer because it really like enabled me to see I could treat anyone really who's walking through the door with these set of impairments that I see over and over again. Difficulty walking, difficulty getting out of bed, vital signs that are unstable when they start doing activity. And the fact that we're not giving an evaluation to someone after a cesarean section to even determine do their
mhm.
vital signs remain stable when they have to encounter an environment where they have to go up and down stairs, where they have to carry their baby from room to room, where they have to get out of a bed that's flat without any handrails. That's your best evidence. And what I hear over and over from OTs and PTs is, well, we don't have any evidence to offer our services to this population. What are your thoughts on that?
Well, I mean, I think we know probably because you probably learned it in school that the gap between research and practice is like a decade, right? So the idea that, well, we have to wait for research and we have to wait for clinical practice and research to kind of catch up to each other before we can see people is not a mindset we necessarily apply to other populations, right? Or to other types of interventions. And especially for C-section in particular, we do have evidence that therapy can be helpful after an abdominal surgery. And C-section is an abdominal surgery, right? It's a major abdominal surgery. Um, I couldn't pull out a research paper to show you for every single patient I see in the hospital, for every diagnosis that I see, right? But I don't say, oh, I can't go see that person unless you give me an RCT showing that my services would be beneficial, right? Like, I don't do that for anybody else, right? Why would I do that for this population? And I also think that we can use, again, we can put on our clinician hat and say, well, we can understand the benefit that therapy would have after an abdominal surgery or after having major blood loss, right? A C section, you lose twice as much blood as a vaginal delivery. And most people go into delivery already having a low hemoglobin and hematocrit as a consequence of the changes that happen to your homeostasis during pregnancy. So we're expecting someone to be deconditioned or to maybe decompensate with activity, right? We can understand the benefit of going to therapy for somebody who's having trouble walking, who has a foot drop, right? I think that, that evidence-based piece is only one part of the stool, right? For supporting clinical care, right? And justifying our services. So I think that we don't need to wait for research. But if you need it, there is research for the conditions for which you would go see a pregnant patient for, right? Somebody who's having, you know, decompensation issues after blood loss, who's had a major surgery, who's having difficulty with mobility or walking, whether it's because of pain or weakness or a neurological condition like foot drop, whether it's a cardiac condition, whether it's blood pressure issues, right? We know that therapy can be beneficial for those populations. So if someone is presenting with those symptoms, there's benefit to therapy seeing them. And just because they also have this diagnosis of pregnancy or postpartum doesn't mean we should all of a sudden throw out everything we know about why therapy can be beneficial for the symptoms they're presenting with.
Absolutely.
Mhm,
Erin, I'm so glad you mentioned foot drop because I
mhm,
remember treating a mom who could not pick up her toes like after birth. And she had already been in the hospital for about 3 days before they finally consulted rehab. 3 days, first of all. Like, let's even talk about like how expensive a postpartum hospital stay is. And
mhm.
then on top of having a delivery that right, it was an uncomplicated vaginal delivery per the note, but yet she's not able to walk. So you can't send her home. So the first thing should be if she's not able to walk is connect the dots to a provider who can help someone walk even with an assisted device like a walker. She had no
Yeah.
walker in her room for 3 days. And so I'm treating this mom and I do something I've done like I don't know countless times with patient populations with foot drop issues with peripheral neuropathy. I use an ace bandage to help her toes lift, right? And we use a walker. She's discharged that day. Like, she's able to discharge.
Mhm.
All she needs was a physical therapy evaluation. She needed a referral to outpatient, but before that, she had consulted with providers who were telling her, "This will take months to heal." Well, yes, on the current trajectory of your plan of care, it's gonna take months for her to regain function because you didn't have us written in the script. And so time and
Mhm.
time over again, when you're like talking about different impairments and things like that, I'm just asking the rehab world to consider what you already treat and apply it to different patient populations. Like, this is not complicated, but we're making it unnecessarily
Mhm.
complicated for people who are giving birth. Like, that's not fair for them. And so to have a conversation like this without inviting someone on who's actually given birth and been through, different complications, like, that to me is a disservice, right? And that's why we're gonna have more of these, conversations
Mhm.
out open in the public. And so I wanna know a little bit about your background in terms of treating on the high-risk pregnancy unit. What do you feel like are the basic things that occupational and physical therapists should just know about treating that population who has a long-term antepartum stay?
So I think from a PT and OT standpoint, the effects of being immobilized to a certain extent or having your activity restricted significantly for an extended period of time, like weeks or even months, is obvious to most PTs and OTs, right? There's going to be a ton of deconditioning. There's going to be a lot of psychological kind of effects of being almost feeling like you're being held prisoner, right? In the hospital, like you're stuck in this room. A lot of times they're told they can't even walk in the halls. You've been ripped away from your life outside of the hospital, your job, your other children, your community, to have to stay in this little room for weeks or months, terrified that at any moment you could give birth to your baby who isn't fully developed yet. So I think that from that standpoint, there's a lot PT and OT can help this population with. But the barrier that I see is that therapists are afraid to work with this population because they're still pregnant and they're worried about doing something that could inadvertently cause someone to go into labor, right? And end up going into labor when the baby's still very young and will have to go to NICU and there could be a chance the baby won't survive or will have major medical complications. And I totally understand that fear. So, something that I tell other therapists when I train them to work with the antepartum population is there's actually not really evidence to support activity restrictions and particularly bed rest level restrictions, which is what a lot of these moms end up on when they're in the hospital in terms of actually producing the outcome that they're designed for, which is to prolong pregnancy. That ACOG, the American College of Obstetrics and Gynecologists, kind of the professional organization for OBGYNs in the US, actually recommends against bed rest for some of the common pregnancy complications it's prescribed for. And the Society for Maternal Fetal Medicine, who are the experts in high risk pregnancy, actually recommend against it for all pregnancy complications, but despite that, it's still recommended in around 20% of pregnancies. And I think something around 80% of OBGYN providers say that they do prescribe significant activity restrictions up to including bed rest in their practice, even though it's not really evidence supported. And professional
80%?
organizations,
Did you just
yeah,
say 80%?
I think that's what it is. I'll have to double check my number. It's in my antepartum course that I'm teaching on June 1st. But yes, like surveys of providers, most OBGYNs still prescribe significant activity restriction up
Oh,
to
I
and
believe
including
it.
bed
No, I
rest.
saw it. Like, it was
Mhm.
such a rarity to actually find an OBGYN who wasn't just routinely telling moms they couldn't get up and walk. It was just like, how many of you are even following evidence-based practice for the pregnant and
Yeah,
postpartum population? Like, this is crazy.
it
There's
is. And,
yeah.
and for the Society for Maternal Fetal Medicine, they recommend against doing significant activity restriction and bed rest because it hasn't been shown to actually prolong pregnancy, which is the whole reason we're doing it. And it has serious negative consequences for mom and baby,
Like
right? We
what?
know activity is beneficial for mom and baby during pregnancy, right? And so lack of activity, right, increases your risk for blood clots, physical deconditioning, right? I mean, I've seen
Mhm.
moms who were on the antepartum unit for a month or more leading up to delivery. And then after they have their baby, they're getting winded just walking down the hall, right? Because they've essentially been in a whole body cast, not moving their body, laying in bed for months. It puts you at increased risk for pulmonary complications, um, and can put the baby at increased risk for poor outcomes because they have a mom who's very deconditioned, right, during pregnancy and leading up to childbirth. So, Maternal Fetal Medicine Society actually recommends against doing it because the negatives outweigh the positives. And it doesn't seem like there's a ton of positives in terms of outcome. So I tell that to therapists I'm training, not because I'm telling them to go tell the mom, hey, your OB that admitted you is wrong, right? And you shouldn't be here necessarily, but to help them allay their own fear that something they're going to do is going to cause the baby to be born. The reality is that baby's probably going to come when it's going to come, whether that mom lays in bed or gets up and is walking around the halls with you or not, right? You are not going to be the reason that that mom goes into labor with the interventions that you're going to do.
All right. Aaron, I I have to tell you something. I had a talk with a rehab manager yesterday, and I was just asking her, like, candidly, because right now my main focus is standing up as many of these programs around the country as fast as possible. And so, what my program, Enhanced Recovery After Delivery, does is it establishes rehab programs in the hospital for women to receive occupational and physical therapy services during their high risk pregnancy and after birth. Now that I've spoken with this rehab manager and kind of over the past 2 years, have been helping therapists figure out, well, what are the barriers in their hospital to providing these services? I had this conversation yesterday with a rehab manager who said she took your section of our paper that we published with the Journal of Women's Health and Pelvic Health Physical Therapy last
Mhm.
year. She took your section on the financial benefits to hospitals
Yeah.
that provide these services to moms after delivery. Took the points that we covered about reducing pain, that we covered about improving function, and that
Mhm.
we covered about reducing the cost for caring for someone because you didn't provide care up front, like rehab after birth. Very, very low level hanging fruit. It's very, very profitable because it doesn't cost much. We're not very expensive providers. We're not the neurologist who has to diagnose peripheral neuropathy. We're the provider who can give you a walker,
Mhm.
right? An interventionist to help with um, nerve palsy after birth. And so she took your section, and that's how she was able to justify starting a program that didn't exist before, where occupational therapy services were offered to women after C-section. Your section of your paper of our commentary, which I've been told is not evidence based, and I said, "Oh yeah." I think so. When you have something so foundational that no one else is doing, you better believe it's as evidence based as it gets. Okay, we're actually connecting the dots for rehab providers to provide their services to an underserved population that honestly has the same impairments as someone after a
Mhm.
cardiovascular event, right? And so what I want to say for you is I can't wait for your programs to drop. And I've been waiting for therapists to come through. Even an organization, we have organizations that are teaching pelvic health courses, that are teaching pregnancy and postpartum rehab courses, that are not introducing acute care occupational and physical therapy in the hospitals after birth. Like that to
Mhm.
me is like foundational knowledge that you should get at NPT and OT school. And so you're dropping your courses April 20th and June 1st. And that gives me full, like, breath of kind of almost a rest from trying to get therapists who have no knowledge in this area up to speed
Mhm.
of just taking vital signs with activity. And now I can focus on those therapists who are actively growing programs in their hospital and actively growing businesses that offer services in hospitals you don't work for. And so tell us about,
Mm.
like, what do therapists need to know to register for your courses? What are they going to get out of it?
Yes, so I'm offering an introduction to acute postpartum PT and OT class. That's April 20th. It's going to be live virtual. And then also an acute antepartum. So that's the high risk pregnancy um, population PT and OT course on June 1st, also live virtual. So you can sign up for them through the Pelvic Health Network class website. I have a landing page there where you can sign up for all of my courses. And we're going to talk about, well, what should you be looking for when you chart review a patient in those units? What are the basics of kind of the physiology of pregnancy and birth you need to know if you're a provider who doesn't really know anything? about those particular events in somebody's life. And we're going to go over what are the most common complications you could run into, what do you need to be looking out for in terms of labs, in terms of vitals, in terms of how a patient is presenting to you in both postpartum and antepartum, and how do you design a basic home exercise program for somebody postpartum, and also how do you design exercise for someone in antepartum that's going to be safe, and how do you teach them how to move in a way that's going to be safe and comply with whatever restrictions that they have. We also will talk about manual therapy interventions for the postpartum and the antepartum patients, and perinatal mental health, which is a section that's been beefed up a lot since the last time we ran this course. And I really identify with what you said about how there's a lot of continuing education around public health out there, but it kind of skips over this time frame, that acute time frame where the super high risk pregnancy admitted to the hospital group. That was a frustration I had when, after I realized, oh wow, I really could be working with patients in the hospital where I already work, but I don't know anything about public health. Let me go take some CEUs to get trained in pregnancy and postpartum care, and realizing, oh, all these courses really skip that super early time frame. They kind of are talking from a perspective of you're working in an outpatient clinic somewhere and someone's coming to see you no earlier than 6 to 8 weeks postpartum. And I'm sitting in this class, the only therapist there that works in a hospital, going, but wait, I'm seeing somebody 24 hours after they have a baby. What about that? And there just weren't really answers for me. It was kind of this gray area, just not a lot of information. And same thing for saying, well, I'm working with someone who's super high risk with complications. I feel like a lot of CEUs say that that's a contraindication to therapy. So they say, well, if you have somebody who has any of these things like cervical insufficiency or preterm labor or preeclampsia, you just need to stop seeing them for PT. And, I'm sitting there again, the only person in a hospital going, but wait, like those people are stuck in a bed in a hospital for months. I think we could do something for them. What could we do that's safe? So that's really why I developed these courses, to help fill that gap in knowledge that I found when I'm like trying to put all the pieces together myself from different places and going in and seeing patients and figuring out what can I do as an acute care therapist in these time frames for these kind of diagnoses when I'm not getting what I need from other rehab courses.
Exactly.
Mhm.
I honestly, I'm so excited. You're working at levels where we need therapists to work at, but I think you're quickly going to move really at the hospital level as well. So I say, honestly, the best way to get this done is with a large enough team as possible. And so we need therapists
Mhm.
at the individual level just to be like prepared for a consult on the high risk pregnancy unit. And that's where your
Yeah.
education is so valuable. But then I'm pushing for hospitals to receive designations as rehab maternity units, right? Because
Mhm.
I want people to know and differentiate between hospitals in their community that are providing
Yeah.
rehab, prioritizing their function, prioritizing their recovery in the hospital after birth before they go home, right? Someone who's actually done an evaluation on their ability to climb a flight of stairs if they live on a third story walk up, right? As a single mom. I want people to
Mhm.
know where those
Yeah.
hospitals are in their community that exist, that provide rehab services before they go home. You wanna
Mhm.
make sure that the therapists on those teams in those hospitals are trained to see that population across the board. We're working in tandem. And so this is a broad
Mhm.
invite to anyone. If you are developing a continuing education course, or if you're a continuing education provider,
Mm.
you know who you are. If you provide women's health or pelvic health continuing education, you're not on the bandwagon of creating courses or information in every city in the United States, the country that has the best maternal outcomes in the entire developed world. Is that right, Aaron? The country that
I
has
th
the
I
best,
I think it might be the opposite.
the
Um,
best maternal health outcomes. If
yeah.
you're not creating and putting out education that creates a huge
Mhm.
maternal workforce, right, that can handle the demand, you're missing out. You're missing out on
Yeah.
opportunities to really improve and enhance maternal health. So please, Erin,
Mhm.
how can I help you? How can I support you in any way? I love what you're doing. Huge
So
fan.
you already are
Number
just
1.
incredibly supportive. I'm so grateful for for you, Rebecca, and for the Pelvic Health Network company that you've created, because it's hosting my classes. Um, it's helped me get connected with even more therapists, right, all over the country who are doing this kind of work. And I think just continuing to spread the word about that this is something that could really benefit moms, could make a difference in the maternal mortality rate. A great point that we made in the paper that we wrote that isn't evidence is that over 50% of maternal deaths happen in the first 6 weeks. And not only is that a gap in the care that's provided in terms of the standard of care in the United States, right? When moms are usually you have your baby and then you don't see anyone for 6 weeks, but it's also a gap in the pelvic continuing education courses that happen for therapists, right? We're missing this whole time frame in pregnancy. So I think by just spreading the word that actually therapy can work with patients in that time frame, we can work with high risk patients, right? And providing as much continuing education to people as we can is going to help close the gap, right? And also advocating on the community end to let moms know that, hey, you can advocate for yourself and there are things out there that can help you, right? There's education for you. You can ask for providers that have had the correct education to help you. I think we could really make a difference.
I believe it. All right, Erin, before I let you go, I have to have a little fun. Have you ever seen the movie Dope Sick?
Nope.
All right. It's horrible. So it goes around it basically talks about like the oxytocin, like how
Mhm.
pharmaceutical companies, like the actual maker of oxytocin. And I hope I'm not like flubbing this up, but um, basically off of a not even a commentary, it was like a letter to the editor. Like they took one line about like pain of some sort, like addressing pain, and they were able to create this like epidemic of opioid abuse because they were able to convince doctors, right, to increase pain referral medication prescriptions, pain medication prescriptions based on this like one line of this editorial or letter to the editor, right, from the 90s or something like that. And I think about a lot like the comments that are like, oh, well, you're not evidence-based yet in your commentary that went over rehab after birth in the hospital. And it's just like one line from a letter to an editor was able to convince physicians to increase their prescription of pain medications and create the opioid epidemic that we saw in the early 2000s. And
Mhm.
I'm like, that there's not evidence to provide occupational and physical therapy after birth, really? And so, yeah, commentaries, case study, like whatever people need to get permission to offer their services, that's fine. We'll
Mm.
work on that, but we're not gonna wait for that to be
Yeah.
published. We're not gonna wait. Like, there's no point. Like, people are, um, unnecessarily suffering, right? When you see someone who's struggling after a major abdominal surgery to walk or carry their baby, and you're waiting for permission, you're not the right person anyway, right? You weren't the right person anyway to provide those services. So really, I want to be clear, like the people that we're attracting to these courses already see that there's a big problem with how
Mhm.
we're offering
Yeah.
rehab to certain populations and withholding rehab to those who give birth. And so I
Mhm.
really want to encourage people like when you sign up for Erin's courses, I sat in on her entire course last year. I kid you not, there's nothing like it, right? I wish I can actually teach that well and just, like, stay on topic, but, I mean, I just brought up dope sick, like, that's kinda how my brain works. Sign up for her course if you want to make an impact with this population in the hospital after birth, during their high-risk pregnancy admission. I cannot wait for your course to release, uh, and yeah, we'll keep in touch. This has been great. Thank you.
Yes, thank you. Thank you so much. Mm.